Okay, we're back. We're on episode 3 of the Debunking series, and we're going to cover imaging myths and the realities of what we can take away from imaging and what we need to be cognizant of and the realities of it. So, before that, Mark, let's hear an update on since we talked last. Last time you said you were starting the improv. How's it going?
Great, man. I actually really enjoy it. I've done 3 classes so far. They're 3 hours each. There's 6 classes total. So, roughly one a week. We had a couple of misses because of weather and then because of a holiday. But yeah, it's good. Altogether, there's probably like 17, 18 people. And I think you can apply anything to physical therapy or other aspects of your life if you really reflect and try to. But I definitely think that if you're a physical therapist or a healthcare practitioner or just somebody in general, I think there are aspects of improv that you can apply to your life or your profession, even if you're not trying to be a writer or a comedian or an actor, because there are some people in the class who want to be in that business. And then there's other people who just wanted to do something different. There's some people who wanted to tackle their social anxiety. There's some people who, just thought it would be interesting. So far it's good.
Have you hung out with any of these people outside of improv? Or do you know anything about them? Or is it like you go in, you bounce?
Well, we introduced ourselves the first day and we've talked to each other, like we take little breaks and they do want to get together this weekend. I'm not sure if I'll do it because it's, we get out at like 6 p.m. and
Hmm.
it's a 30-minute drive from where I'm at. So I'm not sure if I'll do it. But very different walks of life, very different perspectives. Like for one lady, she's just doing a Los Angeles bucket list. So she's been in the United States for 18 years, but she was born in South Korea, but she's been in the United States for 18 years. And, for whatever reason, in a few months, she's, getting booted from the country. And so she's not going to go back to South Korea. Like she's saying that she wants to go somewhere else, maybe in Europe. But she's like, okay, well, now that I only have 3 or 6 months or however many months it is left in LA, I'm going to do all these LA things. I'm going to do improv. I'm going to do surfing lessons. So I think that's kind of cool. On the first day, 2 things that I took away from it that I think you could apply to rehab is one, the importance of active listening and really listening. And I think as physical therapists, as clinicians, when we're listening to patients, a patient could be mid-sentence and in our head, we're already thinking about how we want to respond or the next question that we want to ask. And in improv, you can't do that because you have to hang on to every word that your partner says, so the very last word. Because you might be saying something along the lines of, I had a great day at school, and I'm thinking about, okay, well, let me follow up about school and how you had a great day there because I got to wrestle with some lions, right? So if I had already started formulating my thoughts about how I was going to ask you about school, but then I didn't wait to hear you say that you had fun because you wrestled with lions, because anything in improv is true, then I'm going to miss that important part of the sentence. And that's going to affect how I react and what I ask or what I say. Um, so that's super important. And that's actually part of it too, is that anything that your partner says, you have to believe to be true. So if you tell me that I'm a leprechaun and, I'm currently surfing on a shark or whatever, like I have to believe that to be true and go along with that. And that ties into like a little bit of surrendering control. That's I think a component of improv too, because you are not at the mercy, but you have to really mesh with your partner or partners or, the people that you're working with. I think that's an important component of rehab sometimes too, especially for, I think maybe the patient or the client, is like that surrendering control and knowing that you don't always have control over how long something's going to take to get better. There's definitely things that you can do, whether it's improving your overall fitness and your diet and better sleep and lowering your stress and maybe doing some exercises. But to some extent, you might not have control about whether it gets better in 3 days or 3 months. And there's plenty of other things, but those are some takeaways from the first day, and obviously we've been building off of that.
That's great. Anything else updates since we chatted last?
No, I don't think so. I told you before the podcast, getting some lunch with our mutual buddy, Derek Miles, 2-time guest on the podcast, and I'm sure future guest on the podcast. He's doing a barbell medicine course here in LA. So yeah, it's going to catch up. Haven't seen him in a while. Maybe get some Indian food, which should be good.
Nice. I have FOMO. All right, let's rock and roll. So we're going to chat about imaging myths. And you wrote an article and a subsequent video for this about a year or two ago. And we're going to frame our discussion based off of those two pieces of E3 content, but we may go different areas as well. Before we dive into myth number 1, can we discuss briefly some of the more common imaging pieces of equipment and devices that in the MSK and orthopedic world, patients and clinicians will interact with the most, and a little bit of which one is beneficial for what, and then we can go from there.
Yeah, so referring to diagnostic imaging, and as you mentioned, we're primarily focusing, or at least we talked about, we're focusing on musculoskeletal orthopedic settings here. So we're not talking about the brain or organs or things like that as much. We're trying to focus on musculoskeletal orthopedic settings. So 2 maybe general categories would be like conventional radiography and then advanced imaging. And for conventional radiography, we're really thinking about x-rays. And obviously there are different modifications of x-rays, like fluoroscopy, which is like a real-time x-ray, or sometimes it's described as like an x-ray movie, like a continuous type of x-ray. And x-rays are generally the first type of imaging studied when it or ordered when it comes to someone needing imaging. It's quick, it's easy, it's relatively inexpensive. If someone has had experience with imaging as it relates to their insurance, oftentimes maybe even your orthopedic surgeon wants you to get an MRI, but your insurance won't approve of the MRI until you've had an x-ray first, because the x-ray is kind of usually the first step in a lot of imaging, and we'll go into that a little bit more. Do you know what the X in x-ray stands for?
I have no idea.
Yeah. So German physicist Wilhelm Röntgen discovered x-rays in 1895, and he was awarded a Nobel Prize in physics in 1901 for that discovery. But he discovered unknown radiation. So the X stands for unknown, as if it was like a mathematical variable, right? Like the X in a math equation is that unknown variable that we're solving for. So he discovered this unknown radiation, which we now call X-rays. And I think perhaps maybe in some places they might call it Röntgen radiation or Röntgen rays. But I thought that was a nice little interesting piece of information there.
So
in terms
of
so in terms of advanced imaging, right, we have things like computed tomography, CT scans, and we could talk about contrast studies with some of this. I don't really think it's relevant for our discussion. Magnetic resonance imaging, and then diagnostic ultrasound, which is different than maybe what some people think of in terms of like therapeutic ultrasound. So thinking about the different imaging modalities, starting with x-rays, like I already said, it's fast, it's cheap, it's really great for bone. It's great for screening pathologies quickly, like, pretty significant pathologies quickly. And then it can be used to determine whether or not another imaging study is needed or what type of imaging might be needed. But, like with the X-ray and the image that you're seeing, that you're receiving, I mean, you can see a lot of tissue still, and it's based on like the colors that you're seeing, like the grayscale colors, right? Like air is going to be black, fat is going to be gray black, soft tissue is going to be gray, bone is going to be gray white, metal is going to be white. So you can still see a lot of these different things, which is why it can be used to screen for a lot of pathologies. Disadvantage of X-rays, they show only significant changes in bone density. So maybe not the best for something like avascular necrosis or stress fractures or some other conditions. Obviously, soft tissues are not well defined, so maybe not the best for that. CT scans, like I said, I don't think, a lot of the studies that maybe we're looking at for our purposes and what we're going to discuss today is relevant to CT scans. They're great for assessing trauma, like internal trauma. If someone's had trauma, great way to get a quick understanding of what's going on in the next step. MRIs, great for soft tissues, ligaments, things like that. They can be used for bone tumors, stress fractures. So like if an X-ray says, hey, you don't have a fracture, it might miss that you have a stress fracture, and MRI is going to be able to catch that. Intervertebral disc type of stuff. So imaging like spine. And then diagnostic ultrasound, which I said is different than therapeutic ultrasound. So for some people, lay people listening, they've been to a physical therapy clinic or another clinic. Maybe they've had their clinician grab this like ultrasound machine, put some gel on it, rub it on whatever body region. That's not the ultrasound we're thinking of. We're thinking about it. So other examples that people might be familiar with, maybe you've been pregnant, or your significant other's been pregnant, or someone has been pregnant, and they get a sonogram, which is like this image of this developing baby. So the ultrasound can be used for that. If you've been to a cardiologist, you get something like echocardiogram, and you're kind of getting imaging of your heart and some of these blood vessels. So that's what this ultrasound is that we're talking about. It's great for soft tissue, great for looking at different fluids. It's not going to penetrate bone, probably not super beneficial for some like deeper structures that maybe are hidden behind bone. So yeah, I think the big ones that we're probably going to talk about today are X-rays and MRIs. And I do want to say, because I read something recently that was somebody was describing an experience that happened to them as it relates to physical therapy, and someone else responded and said, well, that's outside the scope of a physical therapist. They shouldn't have done that. And I do just want to mention, so we're both physical therapists. In some states, and I have the list of the states up, this is from the APTA, American Physical Therapy Association website. In some states, physical therapists are allowed to refer for imaging or actually order imaging. And each state is going to have different laws: Colorado, Utah, Wisconsin, North Dakota, Rhode Island, District of Columbia, so DC, New Jersey, and Maryland. So I do want to, that's important to know. And if you're a physical therapist in one of those states, you can obviously look at those laws more in depth. I'm in California, you're in Washington. Doesn't necessarily apply to us. Some practice settings, if you're in the military, you have a little bit more autonomy with what you can do with imaging. And then, every physical therapist, every physical therapy student learns about imaging in school. I'm not saying that it's our job. It's not our responsibility to interpret imaging and provide a patient with a pathoanatomical diagnosis. But I do want to say that we're not completely oblivious to the implications of imaging, especially as it relates to how it might affect, rehabilitation, or whether someone might be a candidate for surgery or something along those lines. I don't know if you have anything to add. And one other thing is that people do, continuing education related to imaging post-graduation. And I think, something like diagnostic ultrasound is becoming more popular. It's obviously very useful and in research, and it's done a lot in research. And I think it's also becoming more popular and performed within the physical therapy profession as well. But yeah, I don't know if you have anything to add to that.
Yeah, we were taught it in school, but it was like a lot of the education was relatively shallow because there was just the breadth of PT education. We didn't dive into the interpretation a ton, and now being in a multidisciplinary setting, seeing how much more education our in-house chiropractors receive in interpreting a lot of images. And then we have another chiropractor that performs the diagnostic ultrasound and how that informs his decision making. And then obviously our orthopedic surgeons. So it is very obvious how little true education we got on it. But also, like you said, there are some settings and some states where that can become more of within our scope and within our responsibilities or potential responsibilities. And there's education pathways to learn more of it. Did you, in your clinical doctorate or in the residency, do you feel like you got a lot in one or the other or both?
Yeah, I think we had a decent amount in school. Once again, I'm not an expert, in it. And then during residency, as part of my residency, it's a university-based residency. So you shadow and work with, the university-based surgeons. And I would say that's probably one of the best ways if you want to learn more about imaging and interpretation of imaging and maybe how people get triaged or referred based on some imaging. So like I shadowed a spine surgeon. And so, yeah, we would look at the imaging together and he would point out, hey, this is what I see here. This is what I'm looking at. So I think that's, super helpful because then you can also get the, clinical interpretation or application of what that might mean to the surgeon. And that way, when you talk to future spine surgeons, you're speaking their language as opposed to just the PT language or the language So yeah, if you're a student, you're a new grad, if you can shadow a surgeon or multiple surgeons, especially if you do want to learn more about what they do, how they practice, maybe how to interpret imaging, that can be really helpful.
Let's go into myth number 1, which you mentioned or you stated in the article in the video. Imaging shows the cause of pain. Why or how is this a myth, Mark?
Yeah, so the scenario that I gave, and I do want to preface all of this by saying that I referenced papers and articles in that YouTube video, in that blog. I'm going to try to stick to most of those references. I think I'm going to talk about some other ones that aren't in that, but that way Chris, who does the podcast show notes, isn't scouring the internet looking for the 20 different references that I mentioned, or I don't have to go through my folders and send him these references. You can just go to the blog and all of those references are linked, because in reality, we're going to talk about some of these, so-called myths. And I think there's an overwhelming amount of research that supports what we're going to talk about. And, we could probably find 100 studies, and I don't want either one of us to do all that work. So the scenario that I gave is that, let's say you begin experiencing pain, you receive imaging, such as an MRI, as an MRI, you discover there's an abnormality. Therefore, it makes sense that this imaging finding is showing what's causing your pain, right? And then I go on to state that, what if I told you that these so-called abnormalities, in quotes, are actually quite common in people without symptoms? And I think the important thing here is that imaging, it's a picture, right? It shows a picture of an anatomical body part or region. It is not necessarily an interpretation of your symptoms or your function or what you're experiencing. And even an actual portrait, like if I took some pictures of you, Chris, there's only so many facial expressions that you could possibly make. You're smiling, you're frowning, you're making a goofy face, you're confused. whatever, but there's only so many that you can do. And with imaging, you take an image, there's only so many things that you're going to find on an image. And a lot of those things are going to be actually quite normal. So some examples that I gave in the knee, this is by Horga et al. 2020, prevalence of abnormal findings in 230 knees of asymptomatic adults using 3.0 TMRI. And it concluded that nearly all knees of asymptomatic adults showed abnormalities in at least one knee structure on MRI. And that included actually 30% presenting with meniscal tears. In the shoulder, I'll give an example from Barreto 2019 titled Bilateral Magnetic Resonance Imaging Findings in Individuals with Unilateral Shoulder Pain. And they evaluated 123 individuals who had one-sided shoulder pain and concluded that most abnormal MRI findings were not different in frequency between symptomatic and asymptomatic shoulders. And if you look at some of the numbers, 90% of shoulders had rotator cuff tendinopathy bilaterally. So that was pretty even between the symptomatic and non-symptomatic side. On the symptomatic side, 1/3, so like about 33% of the symptomatic side had a partial thickness tear of their rotator cuff. On the asymptomatic side, about 1/4, so 25% had a partial thickness tear of the rotator cuff. And then, like I said, there are countless examples of different diagnoses at different body regions. And, some researchers, some clinicians have referred to some of these things as kind of normal age-related changes, like similar to wrinkling of your skin or graying of your hair, and probably a systematic review that's cited and referenced, more often than almost any other paper kind of like talking about imaging is, I don't know how to say the name, Brinjikji. How would you guess that?
Was it like Brzezinski or something?
That sounds good enough to me. 2015, systematic literature review of imaging features of spinal degeneration in asymptomatic populations. And what they do on one column, they have all these different imaging findings: disc degeneration, disc bulge, disc protrusion, facet degeneration, spondylolisthesis, and then, across they have the different ages. So if I take an age 40, 68% of people have disc degeneration. 50% of people have a disc bulge. 33% of people have a disc protrusion. 8% of people have spondylolisthesis. So it shows that. And then if you go up in the age, so if I look at the 80-year-old, the 80-year-olds have 84% of them have a disc bulge, as opposed to a 20-year-old, 30% of them have a disc bulge. So it just shows that in asymptomatic individuals, we're going to find these findings. And then the last example that I kind of gave in this section is a car accident example, meaning that you're driving at the moment, and the year leading up to this moment, you're completely pain-free, no low back pain. You're sitting at a stoplight, you get rear-ended, and you develop low back pain. Now, for one reason or another, maybe it has to do with insurance, maybe it has to do with your hospital bill. You go and you get imaging. X-ray doesn't find anything. Well, I know I'm having back pain. I know it's real. Let me get an MRI. You get an MRI, and that MRI finds that you have a disc bulge. And you go, well, okay, I had this car accident. I didn't have pain beforehand. I have pain now. I got this MRI and I have this disc bulge. Therefore, this disc bulge is the reason for my low back pain, and it was caused by this car accident. And as much sense that makes when we speak it or when we say it, we can't necessarily say it to be true, that it has this, there's this cause effect here. So I think that's what I mean when I say the myth is that imaging shows the cause of pain. And maybe we could add some nuance to this in all scenarios, in all cases. There are going to be cases, and we're going to discuss this as we go on, But I think that is a myth, that if we find a pathoanatomical abnormality, or what we would describe as an abnormality, it's the reason you have pain. When in reality, a lot of these changes are actually quite normal in people with or without symptoms.
When you were in clinic, when this came up with a patient and they brought in their imaging findings, or they discussed one of these cases of what was on their, on their imaging, did you feel like trying to explain it to them a lot of times was well received, or do you think there was such an ingrained nature of this is what it is, this is how it has to be fixed? A lot of times there was either pushback, or you're just like, okay, this isn't really changing their views on the structure being the root cause.
Goes back to that improv example to start, which is you have to believe what they say to be true. If they believe that the MRI that shows that they have a disc bulge is the cause of their low back pain, then I believe that that's their truth, and I'm gonna work with that. And how I respond, or how you respond, or how someone else should respond is going to depend on that specific scenario and the context of that scenario. If that person got the image and they just came back from the orthopedic surgeon, and the orthopedic surgeon said, hey, this is the reason for your pain, and they've been seeing this orthopedic surgeon for 7 years, they have a really good rapport and relationship with this surgeon, I'm not going to go in there most likely and just say, well, actually, he or she is wrong. Let me show you the data about why he or she is wrong. But it could be a conversation that we have over the course of time. I have to ask myself, is it really worth trying to fight this battle on this initial consultation when I can lose my own rapport? Or are there other things that I can do, other things that I could educate this person about, and then maybe come back to it if it's necessary? So there is no one size fits all with regards to how you're going to approach this conversation with somebody.
That makes sense. Anything else you want to discuss about myth 1, imaging showing the cause of pain?
No? Have you had similar experiences?
Yeah, it seems like a daily or weekly experience. And like you alluded to, a lot of it is time and place. Are they asking specifically my opinions on the image? Do I feel like this will be well received? Do I want to kind of trickle this in throughout their plan of care, and have discussions throughout, as opposed to has to be acknowledged day one. And then sometimes I will frame it as this is a fact of what your imaging is showing. Fortunately, this what we're seeing can be common for people who don't have symptoms. And from our perspective, or from the physical therapy standpoint, this structural change isn't something that we're that focused on. It's more on what your goals and values are and what you can get back to. And we don't have to change those findings that you're showing me to do that. So it's kind of redirecting attention to the task at hand, as opposed to things that are most of the time not within our realm of possibility. Let's go myth number 2. Imaging predicts your outcomes. So is that true? Why is that a myth? What's going on?
Yeah, so what if your symptoms are correlated with your X-ray or MRI? So maybe not the cause or the sole cause, right? But what if your symptoms are correlated with your imaging? Does that mean that the worse the imaging looks, the worse your symptoms, function, and long-term recovery will be? Not necessarily. So an example is bigger disc herniations or greater nerve compression seen on MRI, don't necessarily or automatically mean you're not going to recover as well. You might have a large disc herniation, by whatever standard of large we want to describe it as, but get better quicker than someone with a smaller disc herniation. So Benson, 2010, paper titled Conservatively Treated Massive Prolapsed Discs, a 7-year follow-up. The majority of these people, which they described as having massive prolapsed discs, had a complete and sustained recovery. I think it was probably something like 80% or slightly above 80%. And they also conclude that there was a poor correlation between clinical improvement and the extent of disc resolution, which probably ties in more with the next myth, but you didn't have to have like that. Your symptoms weren't necessarily tied to how much that prolapse regressed. A more recent paper, which is not in the blog actually, Dunsmuir 2022, titled No Correlation Identified Between the Proportional Size of a Prolapsed Intervertebral Disc with Disability or Leg Pain. So they say the results of the statistical analysis show that there is no direct correlation between the size or position of the disc prolapse and a patient's symptoms. The symptoms experienced by patients should be the primary concern in deciding to perform discectomy. So you're not just deciding to perform surgery in that case because of how big this disc herniation is or this prolapse is, but instead how the person is presenting. And then as it relates to like nerve compression, so this is Karpinen 2001, severity of symptoms and signs in relation to MRI findings among sciatic patients. So results, the degree of disc displacement in MRI did not correlate with any subjective symptoms, nor did nerve root enhancement or nerve compression. Conclusion, the findings of this study thus indicate that MRI is unable to distinguish sciatic patients in terms of the severity of their symptoms. So if I just put 10 images in front of you, Chris, or let's go even bigger than that, 100 images in front of you, you're not necessarily going to, and I told you that they're all symptomatic. And I said rank them from most symptomatic to least symptomatic or most functional to least functional. And let's say they're all relatively the same age and, you know, everything else is like remaining the same. You're not going to be able to say, okay, this person is most symptomatic and least functional, and this person is, you know, the opposite. It's going to be very hard to do that just by looking at an image. And then if I asked you, well, in 6 months, who's going to get better? In 2 years, who's going to feel better? You know, you're not going to be able to predict that just looking at the image. You have to take the entire clinical presentation into account. And the last example here, osteoarthritis. So symptoms associated with OA don't always match the degree of change on imaging. So you can have minimal to no pain or loss of function, yet have significant bone spurs and joint space narrowing. And do you ever, how much time do you spend on Twitter? Do you spend any time on Twitter?
Very little.
So there are some surgeons on Twitter, and I think it's, I don't know if it's a running joke, but what they'll do is they'll show an x-ray of somebody's knee, and based on the radiologic findings, you would say, okay, well, this person is probably in a lot of pain, you know, their function isn't great, but in reality, you know, the person has had this knee for a very long time, and they finally came in because they have a little small complaint. And it seems like the person that they are referring to a lot of the time, like, do you know what type of person this might be that, you know, comes in with this like knee that you would expect to just be, you know, hurting and like stop you from doing everything? Like, do you know what kind of person? Do you have any guesses?
Say that one more time.
Like, if someone came into your clinic and you saw their knee and you saw their x-ray and you're like, man, that thing looks bad. Like, I'm expecting this person to be on a 10 out of 10 pain and, you know, using an assistive device or in a wheelchair or whatever, but in reality, they're doing just fine and they just have a slight discomfort. Like, do you have a guess of what it seems to be like a running joke or like a theme with the type of patient that is described, or at least I see described on these like Twitter case studies?
Is it like older, more active adults?
Yeah, so it seems like the theme is it's often farmers, right? Farmers just have that mentality of like, I got to take care of this. I'm gonna, probably pull myself up on my bootstraps. I'm gonna work hard. I don't care about my knee. Like, there's more important things to think about. Um, so I thought that's just kind of interesting. And you see that X-ray though, and you're like, yeah, I could see how you would think that this person needs a knee replacement immediately, but the farmer is like, no, my knee has looked like this for 20 years. I just, thought I could come in for some cream or something. Um, and so, but the downside of just looking at this imaging and determining how someone is feeling or trying to predict their outcomes isn't very helpful. And we've all heard the language of bone on bone. So, hey, your knee is bone on bone, or this is the worst knee that I've ever seen. And what that can do is it can cause patients to fixate on an image. It can cause them to catastrophize. So, thinking worst case scenario, it can force them to discontinue meaningful activities, and it can cause them to lack faith or trust in what you're able to do as a physical therapist. So imagine they're coming in and they say, my doctor, who's been doing surgery for 20 years, just told me that this is the worst shoulder or knee or hip that they've ever seen. What possible thing could you as a physical therapist do for them if this surgeon has been doing what they do, which is surgery, for 20 years, and now after 20 years of practice, this is the worst one they've ever seen? Well, they've done surgery on less. They're going to do surgery on me. This physical therapy is a waste of my time. This is the worst thing that, this is bone on bone. Well, bone on bone means there's no cartilage, there's no cushioning. I need to stop squatting. I need to decrease my steps. I need to be careful about how I go up and down stairs. Like that language, based on this imaging and how it supposedly predicts your outcomes, can have very drastic effects on somebody's life and trajectory.
Yeah, I think this goes into both myth 1 and myth 2. There was a patient that I saw a few weeks ago that I eval'd. She is a delivery truck driver, and years ago she had an incident in the same shoulder, and she was off work for like 9 months, but she managed it non-surgically and she got back to work. A few weeks ago, she had a similar situation. She was moving a box, felt a pop, and had some radiating symptoms down the shoulder or down the arm, and had some kind of immediate loss of range of motion. She came and saw me 2 days later, and she was concerned that she was going to have another situation where she was going to be out for almost a year, that she was going to have to go get imaging. And I told her, at this point in time, the things we'd be majorly concerned about for imaging would be any type of acute fracture, anything that would require kind of emergent surgery. But it's too early to say whether or not now none of those seem like that's something to be concerned about or to get imaging. These other things, I think we need time to see how the shoulder settles. And so I reassured her that, maybe there is something going on if we do look at imaging, but fortunately this happened years ago and you managed it non-operatively. And let's give it a few weeks just to see how the shoulder calms down. And I gave her some light kind of dowel range of motion based activities. And a week later, she had full range of motion, still had some symptoms in loaded positions. But over the past few weeks, we've worked in some sideline kind of shoulder flexion and abduction. We got her standing, doing some rowing and pressing this week. And it's this reassurance that maybe there is something on imaging, but do we necessarily need to go down that route? And fortunately, she consulted with our orthopedic surgeon this week because she had to transfer care across providers, and he was on the same boat. He said, yeah, I don't think you need any imaging. It's really not going to change your plan of care. Continue with PT. If things change, then we can go from there. But it's this reassurance that if you do have an acute onset of pain and limitations, that doesn't inherently fast track you to getting some type of imaging 100% of the time. Obviously, there are some instances, but for a lot of individuals, it's reassurance, letting time and natural history do its work, and then progressively getting back to things without that ingrained, like, okay, I immediately got imaging. Now I have this thing in my head of what's going on with my shoulder or my knee or whatever. And that really like anchors them to this almost inability to see non-surgery as an option. Anything else with imaging predicting outcomes, or you want to rock and roll to myth 3?
Let's rock and roll, because I wasted too much time talking about the farmer.
Farmer was in my head, but I was like, I don't want to get this wrong. So I made it more broad. It's an older adult. But yes, the farmer, I know exactly what you're talking about. Myth number 3, if you fix the image, you fix the pain.
Yeah, so I'm going to keep this section shorter because I do think that we could talk about a lot more for some of these other sections. But the example is you have a degenerative tear of your meniscus, you get arthroscopic surgery, you clean it up, then your pain should go away. Your function should be better. You should do better in the long term. But we don't have this linear model. It's not you mix the eggs, the flour, and the sugar, and then you put that in the oven, and then you bake it at a certain temperature, and you pull it out, and you got a cake. It's not like, hey, we see this thing on imaging, we cut it out, we fix it, we remove it, we do whatever. Your symptoms are good, and your function is better, right? And so I give examples for arthroscopic surgery for meniscal tears. I talk about cervical radiculopathy, but we see this more and more in terms of surgery not always performing better than sham or placebo surgery, or even just a wait and see approach. So doing nothing. And so in many cases, we've put the cart before the horse, in the sense that we saw these findings on imaging. The person also happened to have pain. Therefore, surgery must have been the right answer. But now, later, which is why I mean we put the cart before the horse, is we're doing these double-blind, placebo-controlled, randomized control trials, and learning that surgery isn't always better in these cases, right? For the degenerative meniscal tears, for shoulder impingement, for whatever it may be. And the problem with this is, like I just mentioned, is that people end up fixating on the pathology or the perceived pathology instead of their symptoms or function. And I've been trying to do more regular Q&As on our Instagram, and people will say, like, well, how do I fix my disc herniation? And I think I've mentioned on several occasions that might not be the right question to ask. We're not focused on fixing your disc herniation. We're focused on, what are your symptoms? What's your function right now? What are your goals? And how do we progress that over time so that your symptoms are manageable, your function is where you want it to be, and you've reached your goals. And in that process, that disc herniation might not change at all. So you might get a MRI on day 1. It shows this disc herniation. You have symptoms, you have function. 6 months from now, you have no pain, you're functioning great. You get a repeat MRI, that disc herniation is still there. It shouldn't matter. We're not focused on what that image looks like. And I think that's sometimes what people focus on. But I think most people would say, I'll take that scenario versus day 1, I get an MRI, shows a disc herniation, limitations and function, and I have symptoms. 6 months from now, I get another MRI. Well, that disc herniation is completely regressed, resolved. It looks great, but my symptoms and function haven't changed. Like, I'll take that first scenario any day, where the image looks quote unquote abnormal, but I'm doing exactly what I want to do. So, that's the problem, is that we get this mentality oftentimes that we need to fix the image, because if we fix the image, it's going to fix the pain. And maybe there are some cases, and we'll discuss that later on, where, hey, we do want to fix, or, whatever we want to call it, fix the image, where, hey, we do need to get the ACL reconstruction, or we do need to, get the discectomy. Like, I'm not saying that these don't exist, but I'm saying that we can't always just apply this linear model that's going to work for any finding seen on imaging.
To that point, an example that I had in clinic was with our own in-house surgeon. It's about 6 months ago, started noticing some diminished sensation in his left hand and his fingers, I think at third and fourth. And he noticed it when he was performing evaluations, when he'd be in a stool and he'd be looking up at a patient, or when he was in surgery. And obviously his concern was if this was to progress, he could not perform surgery in a safe manner. So he ended up getting immediate imaging, saw some changes in his cervical spine, but we don't know if that was acute or if that's been there. I don't think he had received imaging in the cervical spine anytime recently. But he consulted with a friend of his, another surgeon, and kind of booked a tentative date for potential surgery if things were to progress and it were to stop his ability to perform surgery. But he wanted to see non-surgical providers first and manage and hope that it just resolves. So he ended up coming out to the physical therapy side, and we had a prolonged discussion with him at the initial consultation of just generally what else has been going on with his life. And he used to be a triathlete and gained about 40 pounds. He has been in and out of being sick the past year, hasn't had any consistency with training. We did a bunch of kind of tests and questions and realized that there's nothing concerning that we think we need to fast track or that we can specifically target. He had full range of motion. He had full grip strength. There's nothing major besides this kind of diminished sensation he was describing. So myself, along with another physical therapist, we framed it more as largely the specific symptoms may be out of our control, but what are these other kind of systemic factors that we can discuss and guide and talk through? And he wanted to get back to his weight as a prior triathlete. He wanted to increase consistency with training, and he wanted to, along with the weight loss, have some redirection of his nutrition. So our perspective and our role and scope was, well, let's see if you have any exacerbation or increase in symptoms as we introduce resistance training and exercise, and kind of monitor these symptoms, and also just kind of keep you accountable for the rest of these other health related factors in your life over the next few weeks, and hope that just your symptoms generally either stay the same or improve. So over those 6 to 8 weeks, really there's no kind of provocation of his symptoms, or they didn't progressively worsen. So they ended up just kind of resolving. And I asked him, like, about 6 to 8 weeks in, what do you think was the reason? Because he ended up getting repeat imaging and it was the exact same finding. And he goes, I have no clue. And I give him a lot of props. It was just this big shoulder shrug. And we kind of alluded to, there's so many variables that we did change in regards to his health. And now, months later, he's in a great trajectory of, he lost 40 pounds. He's back into cycling, swimming, training. And that little kind of change in his status of having that sensation lost, fortunately, he didn't have to get surgery, but also it kind of redirected him towards habits that he had lost over the past year or two. And that was a great example of, okay, the findings, fortunately, or not fortunately, but they just stayed the same, but his symptoms resolved, and we can't really say what it was, but that's an example of, it may not matter if they change because they've gone away, and we can also focus on these other things that maybe provide maybe some help, but also just generally being a healthier human. So that was cool, as the surgeon being open-minded enough to realize that that's the case, and also know that his structure's still the same and he's not having any symptoms. So any thoughts there?
I think sometimes, we probably don't discuss maybe sometimes how these changes occur. So we talk about these age-related changes, and you can imagine we compress our nerves all day long. All of our nerves, we sit, we stand, like everything that we're doing, we're compressing nerves, right? And thinking about a disc herniation or whatever, if slowly over time you have this bulge or this prolapse and it progresses and it's like, pushing on this nerve and it's pushing on this nerve, but it's happening slowly over time. Maybe there's not a lot of like inflammatory markers present. Like, it's very possible that you're just adapting to that and you're not going to have any issues. Versus like, if let's say you did get an MRI today and you had, no disc herniation, and you got an MRI tomorrow and now you did have this big disc herniation, and now it is pressing on a nerve, well, then maybe that one is contributing to some of the the symptoms that you're experiencing because of like how it happened so rapidly. Your body didn't necessarily have the time to adapt to that quickly. And I think that does occur in a lot of different scenarios where we say, like, yeah, this is an abnormal finding, but in actuality, it's just gradually occurring over time, which is probably why, you're not really feeling any symptoms. You're not really, feeling a loss in function. Like people can have, a full rotator cuff tear, right? Like you might check someone, oh yeah, you got a full rotator cuff tear or a partial tear. And they're like, oh, my function is fine. Versus maybe you go skiing and you fall and you tear your rotator cuff. Well, like, yeah, you're probably not going to have full function right then and there because of the way it occurred.
Myth number 4, imaging dictates rehab.
Yeah, so if you just fixate on an image and the supposed implications of that image, you could create a self-fulfilling prophecy. So my knee is bone on bone, so I can't run. There's a herniated disc at L5S1, so I stopped going to the gym. I have a pinched nerve in my neck, so I don't play golf anymore. But there's 4 things to remember. 1, most or many so-called abnormalities are common in people without symptoms. Imaging, this is 2, imaging doesn't necessarily predict long-term outcomes. 3, some imaging changes can resolve on their own, which we talked about. So maybe that disc herniation does regress and resolve on its own. Or 4, even when imaging changes don't resolve, symptoms and function can improve. So that's the example that you just gave. In the blog and YouTube video, I gave an example of, someone with a meniscus tear who's 37 and someone else who's 21, and how they might have different lifestyles and habits and goals and things like that. And so how you structure rehab might differ between that 37 and 21-year-old. I want to give some other examples. So let's talk about plantar fasciitis. And, I've written and spoken about this at length. But if we just imagine that people who experience plantar fasciitis exist on a continuum, which is not going to be a perfect continuum, but on one continuum, let's say we have these active individuals, these runners, and let's say that runner gets plantar fasciitis. And then on the other end of that continuum, we have someone who's sedentary, has multiple comorbidities. We're not going to treat those 2 people the same. If we treat them the same, we're missing one of those people. So for that runner, the focus of rehab might be addressing their running program. Hey, what can we do to change your mileage, your speed, your frequency? Can we throw in some strength training? Can we, whatever it may be, there's a lot of different options, but it's probably going to be focused more on their running. Whereas that person who's sedentary, who has these comorbidities, it might be, hey, what do you think about starting a walking program? Is there anything else that you want to do to see if we can improve your overall health and quality of life? That rehab is going to look very different. So they might have, and usually we don't necessarily need imaging for plantar fasciitis, but let's say, they were diagnosed and they had a thickened plantar fascia or whatever, but we're not going to treat them the same because their presentations and their context is completely different. An example for an ACL, because I did bring this up, there was a time where I saw a woman who was, I want to say either late 50s or early 60s, who came to see me after an ACL reconstruction. First ACL reconstruction that she's had. The mechanism of injury was that she was on a plane, she was putting her luggage overhead, her knee hurt, she went and saw the surgeon, did an MRI, ACL was torn, immediately went into surgery. There was no preoperative care. What were her goals? Is she a professional athlete? No, she just wanted to do some basic exercises at the gym. Like that's what she liked to do, just go to the gym. I'm not talking like she's not doing these, she's not powerlifting or even things that don't even really matter anyway for an ACL, just like really basic gym exercises. I might question whether or not she was the most appropriate candidate for an ACL reconstruction, especially considering that she didn't do any preoperative rehabilitation. Now, if you take somebody who's the number 1 prospect in soccer or football for our non-American listeners, and they're doing a lot of pivoting and cutting and they're young and they're otherwise functioning super well, and then they tear their ACL. And, like immediately, even before they do any kind of preoperative rehabilitation, or even like, let's say 3 months of rehab to try to get this quiet knee, or 6 weeks or 12 weeks, we're still probably saying, well, compared to the other case, this person is probably going to be a better candidate for an ACL reconstruction. So same diagnosis, torn ACL, but just hearing the difference in the cases, you're thinking like, okay, well, yeah, this young prospect athlete, better candidate than this person who just put their luggage overhead and, their knee started hurting. And I don't think we're going to have a lot of time to discuss this. I've been wanting to discuss this for so long now. Spondylolisthesis. I've gotten better with my nuance as it relates to blogs and YouTube videos, but it's still challenging. There's still pushback. I appreciate any challenges. I appreciate any feedback. You read, the comments on the anterior pelvic tilt YouTube video, and, you'll see all the pushback. But I do think that in some videos, especially that ones that I or we provide exercises, even more nuance is required. And so the spondylolisthesis video that I, made and wrote, I don't know if it was 1 or 2 years ago, I included exercises to strengthen the back extensors. And if you go in those comments, people say like, that's the worst thing that you can do. How is this guy a physical therapist? Don't ever do these things. And I did try to provide nuance. But, one thing that I want to say is that the majority of research suggests that spondylolisthesis is common, present in the asymptomatic population, and for the most part is not correlated with low back pain or physical disability. So at face value, you hear spondylolisthesis and you're thinking, yeah, that person should never do back extensions, maybe. Or, even stenosis. Like, no, they need to do flexion. They shouldn't do back extension. But what if this person is this example that I'm giving is that they had no back pain. They suddenly develop low back pain. They do imaging. They discover that they have spondylolisthesis, but maybe that spondylolisthesis isn't necessarily relevant to their low back pain. Or what if they have that and it is relevant, but you have them do back extension strengthening and it feels great for them and they love it? Are we automatically going to say, let's stop doing that because of a diagnosis? Or should we base it on the presentation? Or the other example that I gave in that video, what if they're a gymnast? Are you going to tell me that this 17-year-old gymnast who, like, this is their sport, this is their college, going to be their college career, maybe it's their source of income, it's their profession. Well, you got spondylolisthesis, you can never do back extension again. Like, sorry, sucker. You're not going to say that. You're going to try to figure out how do I progressively adapt this over time? And the answer might be, hey, yeah, you know what? You're really reacting like poorly to back extension. Your symptoms are really irritable right now. Let's not do that to start, but to meet your goals, we probably want to do that. Yes, I just had to throw that in there because that's one that I've been wanting to talk about for a really long time. But it's just like, with no context, we're basing our entire approach to rehab on an image as opposed to a person's presentation.
That was good. Thanks for bringing that up. All right. Myth number 5, the last myth. Imaging never matters. You alluded to this earlier, times when imaging can very much dictate going towards a surgical route or when it would be extremely helpful.
Yeah, so I'm going to read the little excerpt from the blog and then I'm going to build off of that. So imaging does matter when applied and explained appropriately. For example, following trauma to the ankle and foot, an evidence-based guideline known as the Ottawa Ankle Rules determines if you need x-rays to rule out the possibility of a fracture. There's a similar set of rules for the neck. These procedures help medical doctors avoid the use of excessive imaging in these scenarios while capturing the people who need specific medical management for their injuries. Most low back pain is unrelated to serious pathology, but there are the rare cases when it's related to cancer, an infection, or something else that requires immediate medical attention. X-rays and MRIs are extremely important in these scenarios. And if there's a time when imaging influences rehab or is used as part of the decision-making process for determining the appropriateness for surgery, then imaging is as useful, right? But there's an overutilization of imaging right now. And we know that the overutilization can lead to increased costs, unneeded treatments, and worse outcomes, because somebody who doesn't need surgery might get surgery based on the imaging, or even if they aren't unnecessarily getting surgery, they might unnecessarily worry about something that's normal or inconsequential. I've seen some pushes from some people who talk about, hey, let's get full body MRIs every year. And ultimately, you get a full body MRI every year, you're going to find some things that probably need to be fixed, or you think they're going to need to be fixed, but I'm not sure that they do. And I'm going to go, this is just based off a little bit more off the spondylolisthesis. This is a really interesting study, actually. So Matsunaga et al., 2000, followed patients managed non-operatively for 10 to 18 years who had degenerative spondylolisthesis. 3 takeaways. 1, development of neurological deficits was not correlated with the progression of slippage, which is really interesting, right? So it happens slowly over time. And maybe you can think of a spondylolisthesis as like your vertebral slippage, like it's a slow slippage, not in the context of like what people normally say, like, oh, my disc slipped. But the development of neurological deficits was not correlated with that progression of slippage. 2, the stability of the spine improved on its own for many of the patients, right? Despite managing this non-operatively for 10 to 18 years. And then the third one, which is actually, I think, is interesting too, the majority of patients who had Cauda equina syndrome at the initial exam had a worsening of symptoms. But generally, we think Cauda equina and we're like, get this person into surgery. But in this paper, they managed them non-operatively for 10 to 18 years. And we don't even know if surgery would have helped those people. It could just be one of those things that they had worse symptoms at the start, and no matter what, they were going to have, worse symptoms, whether they had surgery or not. But that could give us an indication that, in those cases where like maybe there was severe or progressive neurological deficits, surgery, might have been more beneficial for them. And you asked me prior to maybe give some examples, like in my own personal practice. I've given this example once before. I had a patient who came in preoperatively for a knee replacement. So he was scheduled for surgery. I did my exam and I was like, this guy does not need a knee replacement. And what I suggested is that he go and see a hip specialist prior to the knee replacement. I don't remember what exactly I told him. What ended up happening was he had a hip replacement. He came back and his knee pain was gone. So he was experiencing knee pain based on, his hip OA and not actually knee OA. They imaged the knee and there was, radiological findings of joint space narrowing and whatever else, but that wasn't the thing that was the problem. So you can imagine that he might have went and had a knee replacement and still had a lot of pain and disability, and then went and had a hip replacement afterward. Luckily I caught that and he ended up having a hip replacement. So imaging was necessary. I didn't refer for imaging. I didn't order imaging. I just suggested that, hey, maybe you go see this hip specialist prior to the surgery. And, luckily he got the imaging. They found what I suspected and they had surgery. In a more personal case, a family member had progressive loss of function, neurologic deficits, and their partner was suggesting that they go get it checked out. But this family member, maybe a little bit stubborn, partner not a healthcare professional. I was over for dinner one night, having dinner, probably watching a movie, and decided to do some tests. And in my mind, I was thinking, okay, this is a progressively worsening cervical myelopathy. And it's been getting significantly, like it was a slow worsening. And then now, based on what, the family member was telling me, a significant worsening in a shorter amount of time. You should probably go get this checked out. You should probably go get this imaged. And they did, and they had surgery. But that's another example. And so the whole purpose of this is that we're presenting this information, or I'm presenting this information, but I'm not saying that imaging never matters. I don't want to get that across. I think it's really hard for students and new grads because we get these maybe dichotomies in rehab and medicine rather than accepting of the gray, where on one side it's like, yeah, we got to image everybody, we got to figure out what's going on. And then maybe a different camp is trying to push back because the pendulum is too far that way. And we say, well, imaging never matters. We don't really need to focus on it. Low back pain is nonspecific. But there are cases when imaging is going to matter. And our primary role as physical therapists is to determine if a patient is appropriate for physical therapy. So there are 3 scenarios. They're appropriate for physical therapy, and that's it. They're appropriate for physical therapy, but they're also appropriate for a referral elsewhere. Or the third one is they're not appropriate for physical therapy and they require a referral elsewhere. So this entire discussion was based on imaging, but we're not just talking about imaging. We're talking about, you might need to, assess someone's vitals, their blood pressure and their heart rate. You might need to ask other questions and refer to a rheumatologist because they need to get some blood work done. You might be a pelvic floor specialist and refer back to their urologist or gynecologist or whoever it may be. So this is not just focusing on imaging, it's making sure that the person is appropriate for rehab, and if not, referring to the appropriate individuals. That's our biggest role, is that people are being seen where they need to be seen. And obviously in our case, that relates to the orthopedic musculoskeletal setting. And oftentimes they don't necessarily need the imaging that they believe to be required for a successful outcome.
Nailed it. In your own clinical practice or advice for younger clinicians and new grads, if there is some hesitancy on whether or not they should refer out or whether or not they're a candidate, do you have the when in doubt, refer out principle when there's more uncertainty or you think there's more going on? Do you have any advice or words of wisdom for determining whether or not there should be further exploration of care or options?
When in doubt, discuss with a colleague also, because you also don't want to be that person, and everyone's going to make mistakes. We learn from our mistakes, but you don't want to be that person where let's say your number one referral, your orthopedic surgeon refers somebody to you for a specific complaint. You do your clinical exam and go, now you need to go back to your surgeon and get this imaged. And the surgeon's like, listen, this person's going to do, they don't need surgery. And let's say that they actually don't need surgery. They don't need imaging. That's probably not going to make you look great because you're second guessing something. And maybe you're only second guessing it because you're not very familiar with the issue. And you're unsure. For something like, let's say FAI, right? Femoral acetabular impingement. Part of the diagnostic criteria is imaging. But if somebody came and saw me or came and saw you and you do your test and you hear their history, we probably don't need imaging. I know it's part of the diagnostic process, but we probably don't need the imaging to successfully manage or, rehab, with them, unless in your mind it's going to change the process, or you're going to refer them for surgery. But if not, well, what is the imaging going to do in that case? So yeah, to your question, when in doubt, do you refer out? I mean, listen, you don't want to miss uh, a vertebral artery dissection, or you don't want to miss cancer, or you don't want to miss, something really serious that needs immediate medical attention. But yeah, I think you're going to learn it over time, discussing with colleagues. What's been your experience? Obviously, you're in a pretty multidisciplinary setting, so that's helpful. But have you ever made the mistake of referring back, or do you just go like, "Oh, I can just go talk to the surgeon and determine if I need to refer back"?
Yeah, with our in-house surgeon, it's great because either in that session, if there's something I'm immediately concerned about, like, a few days out and I'm concerned of a blood clot, or I think there's something that would require like an immediate consultation, I can go see the surgeon or I can talk to him privately. Outside of our own clinic, there's one example that I thought of with a patient that I saw yesterday. But initially, when I evaluated her months ago, she was coming in for chronic low back pain. And I forgot when or how she mentioned this, but she was like, yeah, I also have this big lump on my shoulder. And I've never really done much about it. And with all of her other comorbidities and everything else that was going on, that was an example where I immediately recommended she go back to her care provider, discuss that, and then decide further treatment options, because it seemed, even if it was something that wasn't a concern or was benign lump, that I want to do my due diligence, and her bringing it up made me feel this should be at least looked at by other providers. So, and to your point, there's a lot of other cases where maybe I don't say anything immediately to the patient, but I consult with other therapists or the other providers within the clinic, and then determine what steps are necessary, whether we should kind of hold course or stay course. And maybe if things aren't changing or if things are getting worse, refer out or give potential other options for other providers. So it's obviously very context dependent, but I fall more towards the let's ask other people's opinions and talk to surgeon, refer to their PCP or their referring surgeon, and not just assume that things are going to get better or just blindly continue with the plan.
Yeah,
I did have one other
like you said.
Go ahead.
Go ahead. Yeah, it depends on how emergent the situation is, right? If someone comes in, hey, I have a pulsating in my abdomen. You can see it. You want to see it and feel it? It's like, okay. Or, hey, I woke up today. My neck is so stiff. I can't move it. I'm also feeling some facial numbness and whatever. Like, all right. A lot of people who see patients post-operatively, it's not necessarily uncommon for maybe someone comes in and they have an infection of the wound. Like, you're going to try to refer back and make sure that they get antibiotics or what it's taken care of. But yeah, there's not a one size fits all answer, obviously. Sorry, what were you going to ask?
Well, to that, another example that came to my head was a youth athlete that came in, and this was his 5th or 6th concussion. And this one, evaling him, trying a Bruce or a kind of a Buffalo concussion treadmill test and other things, like he couldn't even tolerate 1 minute of walking on the treadmill, and he would get these pulsating severe headaches just sitting on the table. And it was so severe, I consulted with other therapists and thought ultimately like I recommended he go to UW's like specialized concussion clinic. And because it was such an extreme case to where I couldn't even start the baseline testing process, it didn't make sense to have him continually come in, flare up his symptoms, and really stay at the same point. And I'm actually getting close to that. This doesn't go to imaging, but this goes to just like referring to other providers. We have I'm co-treating a 9-year-old gymnast. She broke her medial epicondyle and she got an ORAF, and she's been so scared and hesitant to allow us to passively range it. And she's been essentially stuck at 90 degrees. I think she has more range, but there's such rigidity and guarding that I want to refer back to like a pediatrics orthopedic setting to where there's other kids running around. There's ped specialty therapists that are ultimately way better at working with a 9-year-old than I am. And that should substantially improve these early postoperative outcomes to where we keep coming in. She's crying, she's guarded, she's scared. It's kind of an older adult or middle-aged adult clinic to where it just doesn't make sense to continue therapy in this setting. So even when it's not referring out for imaging, referring out to other either specialty PT providers or other providers, like you said, rheumatologists, whatever the situation is. So that was a few other examples I wanted to provide. And then my last question was to the individual that you're talking to or evaling, and they are concerned of their presentation or they think imaging is warranted, and you maybe like pull them back or talk them off the ledge. Do you also provide, these are the things, this is XYZ that we would be concerned about that would have us warrant imaging? Like, do you bring those things up for them to know, okay, this is what would have me think this is more concerning? Or does that in your head also instill a little bit more like hyper awareness and fear of the situation?
Yeah, if it's going to provide reassurance to the person and you're pretty confident in that reassurance, then I think it can be helpful. So maybe an example is a person has low back pain and they're in their 20s, and like there is just nothing, there are what we call red flags. There are no red flags. Their symptoms are very mechanical in nature, meaning that they go, oh, when I bend this way or I twist this way or I lift this way, it hurts. When I do this, it feels better. They have a very clear mechanism of injury. They have all these things, but they go, I read online that low back pain can be cancer. Well, then like in that example, you might say, well, this is what I would normally look for if I suspect someone to potentially have, cancer. You don't have this, you don't have this, you don't have this, you don't have this. Like, how does that make you feel? Like, oh, okay, I didn't know that, like, you were looking for all those things. I just read that low back pain could be cancer. Like, that makes me feel better. In that example, that might be helpful. And, there's going to be the rare case, like, where that happens and it's a 1 in a million type of thing where, maybe that person does have cancer, but, obviously we're, basing it on, the general statistics of things.
All right, Mark. Any other final thoughts? Summary? Anything you feel like we didn't address for this episode?
No, I think we did a pretty decent job. We're still, you know what? I know our podcast editor has been loving these debunking series episodes. So all you listeners, tell us what you think. Maybe you can influence what topic we talk about next. We're open to whatever. Let us know.
Shout out to Matt Hunter. All right, we'll call it there. Thanks, Mark.